Good afternoon, everyone. Thank you for joining us on our Thursday afternoon webinar. I am Melinda Bikini, Director of Patient Advocacy with the Cholangiocarcinoma Foundation. And today we are happy to be joined by Dr. Tim Greten. Dr. Greten is Senior Investigator and Co-Director of the NCI-CCR Liver Cancer Program. He's received training in Medical Oncology, Gastroenterology, Hepatology, and also Tumorimmunology, and has been studying immunotherapy of the liver cancer for almost 20 years. Dr. Greten, thank you for being here. We're so excited to have you and to learn more about the research you have going on out at NCI. I will turn it over to you, but I'm going to let everyone know that if you have questions throughout the presentation, please put them in the Q&A or the chat box, and we will have our Q&A session at the end. Thank you.
All right. So thank you, Melinda, for the kind words and the introduction. Let me share my screen. And where is my talk? Let me see. It doesn't show up. It should show up. 1 second. Dum, dum, dum.
There you go.
All right, here we go. So why don't we get started? And please feel free to interrupt me, actually, if you prefer in between. I'm trying to make this a little bit more interactive, if possible. So
that sounds good. And I'll let you know if there's any questions that pop up.
Right. So the question, I'm trying to answer is immunotherapy a good treatment option for all patients with cholangiocarcinoma? And what I guess what the real question is it a good treatment option, number one? And is it a good treat, or is it a treatment option for all patients with cholangiocarcinoma? And I'm going to try to answer some of those questions, but before I go there, let me just tell you what I have to do. So I'm going to show you some data that we have obtained at the NCI, and that was with support between AstraZeneca and the NCI and Merck and the NCI. However, I did not had any direct benefit from this. And before I go there, I'm going to maybe use 5 minutes to explain a little bit to you what we actually do in Bethesda. I know Melinda, obviously, she knows this very well, but I think, I want to tell you a little bit about this and then turn to why immunotherapy in cholangiocarcinoma, show you some results, and basically going to tell about our own data, ongoing data, and what we see in the possible future. So this is a picture of the NCI in Bethesda, which is close to Washington, as you all know. It's a very, very large campus. And what you can see here is in the front is the clinical center. And all this around here, all these large buildings are all research buildings. And the way I explain this, it's really a regular hospital actually here in front, with everything, your ICU and anything that you want. But the main thing is we don't have an emergency room. So all patients really come by invitation or appointment only. What we do at the NCI is anything for translational and a lot of clinical research, and those are the clinical trials. And then there's some research on HIV and AIDS. Now, just to show you how this actually looks like. So it's a regular hospital. You can see this. This is a picture from our floor where we see our patients, and the outpatient unit where patients receive their treatment. There's a lot of parks actually around. We have a lot of wild animals around because it's a government institution, so it has a huge fence around. So all the animals inside are actually very well protected and have a happy life. And you see, us doing rounds, and you see my team here. This is a very a recent picture from us where we were still wearing masks, as you can see, and treating patients. Yes, hold on to me. Just give me 1 second. Okay, sorry for the background noise. Anyhow, so this is this is where we treat patients and regular inpatient unit. Now, the important thing for you to know is what we do is we provide second opinion for patients with cholangiocarcinoma if this is needed. So in other words, if this is needed, it means if they're not already at one of the leading centers, I don't think, we want to compete with them. We provide or we conduct clinical trials for patients with cholangiocarcinoma. And the special thing is that enrollment in medical care is 100% free to all of our patients. And the NCI provides help in travel. They actually pay for your travel once you're on the trial, as well as support for food and lodging, and if you don't live in the area. So with this, let me move to the question, why immunotherapy for cholangiocarcinoma? And the reason for us was actually very easy. When we started this in 2013 or 2014, we did this based on a clinical trial, which I'm going to show you in a second. Now, the situation has changed, and I'm sure a lot of you have seen this, that there is data from a large randomized study where they tested immunotherapy in combination with chemotherapy. And I'm just going to browse through this, where you see there is a change in the median overall survival in the patients receiving this one immunotherapeutic drug, the durvalumab. Now, we can talk about the significance of this finding, but nevertheless, this is a large randomized phase 3 study, so you can't really ignore this. Now, so how did we come? And I told you, how did we actually came through this because we have been interested in doing immunotherapy for liver cancer for many years, and we started in HCC. And this is the result from an early study that we started back in 2013. And what you can see here is response of lesions in these patients. And what you basically can take as a take-home message is that out of these patients, you see that there's a significant number, obviously, unfortunately not all, but a significant number of patients that actually showed a response. And they showed a very long response over many months. Now, that basically, caught our interest, and we thought, if this works in HCC, maybe, it may work in cholangiocarcinoma just as well, cholangio being a primary liver cancer. Unfortunately, it didn't. And this is the result from the study. And what you can see here is that there really is only one patient that, showed a response. And I'm going to show you a little bit more about this patient. And the majority of these patients really didn't show any benefit to this treatment. So this is, the outline of this study. Again, we published this in the meantime, started this, I believe, in 2014 or 15, and then got the results. We started with anti-CTLA-4, which is one of the agents that we use to induce strong immune responses, and performed correlatives on blood samples and biopsies, and performed imaging. As you can see on this outline, and this was a small study, 20 patients. I think it's relatively characteristic to or similar to what we usually see in these type of studies. The majority or all these patients had received prior chemotherapy. Some of them had intrahepatic tumors, some of them had a gallbladder cancer, and some had an extrahepatic cholangiocarcinoma. And you have seen this picture on the left already, and this just shows you, that the majority of these patients did not benefit very much, but it actually does work. If you really look carefully, it's very hard to ignore this one patient. And this is a time course of this patient. And allow me to tell you that I've seen this patient, I think 3 weeks ago. She is still without any evidence of disease. So she is tumor-free, basically. And you can see she was initially diagnosed in 2006. Then we started her treatment in December of 2016, and now it's 2022, and we 5 years out, she's without any evidence of disease. And I'm not going to bore you with the details, what happened to her and all the clinical course. But what it clearly shows is that immunotherapy can work. Remember, I wanted to answer this question, does it work for all patients? Well, I don't think we really know yet. We don't know why it doesn't work for all patients, but there are certain indications suggesting indeed that it does work, because otherwise it's very, very difficult to explain why there are patients that respond so well to treatment. Now, at the NIH, obviously, what we're trying to do is we're really trying to analyze and do tumor samples and perform very thorough correlative analysis to better understand why some patients respond and others don't. I've got to be honest, unfortunately, in this particular case, we still don't know it, despite numerous efforts that we put in here to better study this disease. So let me tell you a little bit, about the results from clinical trials. What I've shown you so far is there is certain evidence that immunotherapy may work. Remember, we have the data from the phase 3 study, large study, many patients, a randomized controlled trial, and there's a benefit for those patients that received the chemotherapy plus durvalumab. Then I've shown you our first study that we conducted at the NCI in patients with cholangiocarcinoma. We noticed that the treatment is less effective just using anti-CTLA-4 compared to HCC, but yes, there are certainly outliers, and I think it's just a matter of time until we better understand this. So this is another study that we completed recently, and Dr. Monhe from my group finished this up, and this is the study where we did something similar to the trial that I presented in combination with chemotherapy. We used pembrolizumab. And again, what you can see from this rather small study that, there's a variety, and there are certainly patients, as seen here, that actually may respond, and we are just, I would say, at the verge of better understanding, why some patients respond and how we can potentially improve this outcome. So what are we doing now? Or what have we done? So based on the initial study that I've shown you, where we only used anti-CTLA-4, now we performed a second study where we now use 2 immune checkpoint inhibitors, the anti-PD-L1, which is very similar to PD-1 that you probably know of, and the durvalumab, basically, which was used in the large TOPAZ study. So we combined 2 different drugs to make the immunotherapy potentially more active. And this, again, was a study that we did in patients with primary HCC as well as in patients with cholangiocarcinoma. And what you can see in this particular study here now is, again, there is a few patients showing response, but not a great response. And what I would like to summarize here is, to complete this is, in those studies that we have done so far with about close to 100 patients, using different regimens, you will see major responses, but it's not the home run yet, unfortunately. And, we're working hard to make this better. We hope we can make this better, and I believe we have some ideas how we can potentially make this better. But at this time, I think it's fair to say to the patient, that this is certainly a treatment option, but for reasons that part of them that we understand, whereas others we don't understand, it's certainly not effective in every patient. So what we're trying to do in our center here is shown here a little bit, we're trying to think outside the box and trying to see how we can, make this more effective and also use approaches that are not that common, I would say. So, and we can do this because we have the luxury of the clinical center that allows us to pretty much perform studies, which some of them may be independent of pharma, and especially we have, we probably have less financial limitations than other centers have. So one of the studies I would like to introduce, which is ongoing right now, is again based on prior data, both from the cholangio field as well as from the HCC field. And what I've shown you so far is I've shown you the durvalumab, and you've seen this. I've shown you data on anti-CTLA-4. You know that this combination is actually now or has been tested extensively in cholangio. I've shown you this, but even more extensively in HCC, and we have data from this. We know in HCC, and sometimes I call this the big brother because it's more frequent liver tumor, we know that the combination of anti-CTLA-4 and anti-VEGF is actually very effective. And the combination of anti-VEGF and anti-PD-L1 is very effective and has actually become first-line treatment. So currently we're doing actually a clinical trial where we combine the three, thinking, if these two works so effective, if very efficacious, this one works a little bit in cholangio, maybe the three are more active, and that's an ongoing study. So I'm going to move now to the third part of my talk, where I would just tell you a little bit about ongoing clinical trials. And And unfortunately, I can't really tell you a lot about the results just because these are really just ongoing. But we believe that the treatment is certainly more effective than what we have seen so far. This just shows you this is infusion that patients get where we combine these different drugs, and patients have to come to the clinical center every 3 weeks to receive this treatment. And then, we see these patients perform imaging, etc., just like in active or standard of care. Now, what I haven't told you yet, and this is certainly something important to keep in mind, is when we talk about the topic, who is this something for all patients, which goes back to the question, how does this treatment actually work? And the reason, or the way this works is it's actually very straightforward. Rather than using any drug that targets the tumor, we actually don't do anything to the tumor. The only thing we do, and I put only in quotes, is, we activate your immune cells, so your lymphocytes that now very well, because we all had to go through the COVID crisis, and how we need lymphocytes to and immune responses to kill a virus. The same way lymphocytes can actually also recognize tumor cells and eliminate tumor cells. So this immunotherapy basically, works by activating immune cells. The problem is that if you do this if the immune system becomes too much activated, you will get autoimmunity, and that is that's the main side effect. So basically, the main side effect is explained by the mechanism of action, immune cells recognizing your own tissue. And I'm sure a lot of you know about Crohn's disease or colitis, ulcerative colitis, and those are side effects that we can also see, and that we do see in our patients treated with immunotherapy. We see skin reactions, but the immune system, can recognize anything in the body, and it does. So, the side effects, which are, I think, in most cases, less severe than what we see with chemotherapy or even with targeted therapy. But it's important to keep in mind that those immune effects or side effects can occur. And it's important to keep in mind that if we ask, who can be treated with this, that patients who already have underlying autoimmune disease, that those patients are in most cases excluded from immunotherapy. Now, I just told you a little bit about how the treatment works. So remember, the idea is that the T cell actually recognizes the tumor cell, but we can also make this not by giving make this not happen by giving an antibody to make the T cells more active. We can actually infuse T cells that recognize tumors, and there's different ways. And I don't want to bore you with too much of the details, but there are more, I would say, intense therapies where we basically harvest blood from a patient, isolate the lymphocytes, and then perform a kind of a gene therapy of these lymphocytes. They are in culture and genetic them in a way so that they recognize specifically tumors, and then reintroduce them into the patient. And there's different ways this can be done, by making T cells and change their T cell receptor, or by something that we call a chimeric antigen receptor, where we basically put part of an antibody on the surface of these T cells so that it can recognize the antigen on the tumor. So here is what is shown here is basically how this is being done. So I told you we isolate PBMC using leukapheresis from a patient. Then these PBMC go into the laboratory, and they are expanded using reagents that we have so that these cells proliferate. And then we perform gene therapy. So we genetically engineer these T cells so that they are changed and are basically changed into a mode so that they can specifically recognize tumor cells. We expand these cells further so that we have enough cells over a period of about 2 weeks. And then after this period of time, we can use these T cells first in preclinical studies to make sure that they really work. This is obviously why there's an animal shown here. So this is what is done. But then once we are in clinic, what we do is we treat the patient with this chemotherapy to basically kill the patient's own, or to kill part of the patient's own immune cells, and then infuse these CAR T cells through the peripheral vein. And the idea is that these cells then go into the tumor and destroy the tumor cell. Now, this is a treatment, I have to tell you, which I think in terms of solid tumors is still very early. You probably, or you may have heard that it's already an established treatment for patients with different types of leukemias and lymphomas. In the context of solid tumors, it's, I would say, still at an early stage, and especially in cholangiocarcinoma, it's more an early stage. Currently, we're performing such study in patients with advanced mesothelin-expressing cancer, but I want to make sure that patients understand this is not a very straightforward and easy treatment. It requires a cell production, as I've shown you. It requires a chemotherapy prior to the T-cell infusion. The treatment requires that patients will be admitted for at least 2 weeks. And because of the chemotherapy that we give you, I remember I told you that before the infusion, we basically have to kill a lot of the lymphocytes which are in the body. We have to be very, very selective with the patients that we treat, because these patients are at a very high risk of getting any type of an infection. And we know that patients with cholangiocarcinoma are very easily can very easily develop cholangitis. And for that particular reason, we have not only to be very selective, but we also actually, unfortunately, have to include patients with biliary stents, which I obviously know is something that occurs, or which is present in a lot of patients. And the second point, which is not on this slide, is also that patients who actually are on any type of a blood dilution, so heparin, etc., also excluded due to the side effects that can occur after the cells are infused. Now, last to tell you about one other study that we're doing, which is actually not a study, an immunotherapy study, but this is a study specifically for KRAS mutated tumors, using a small molecule, trametinib. This is based on data from colleagues who had initially tested this in pancreatic cancer, and then we tested this ourselves, or I wouldn't say we tested this, we had some experience. This is one of the patients that we saw that had a pancreatic cancer, and we treated him with this combination of trametinib and hydroxychloroquine. And you can see how the patient here, the CA99 level, responded very nicely to this treatment. And we are now testing this in patients with KRAS driven, so in other words, KRAS mutated refractory biliary tract cancer. The nice thing about this study, which again, all these studies happen at the NIH, so patients have to come to us. The nice thing about this part is that this is a study which uses oral drugs, which obviously makes the treatment a little bit easier. So with this, I just want to tell you, a very, very brief look into the future, and then, I would be more than happy to answer any possible questions that you have. So where do we go? So remember, I tried to tell you, and the first thing I want to make sure is, obviously we're not the only one doing immunotherapy, and I just decided to show you our own studies rather than, talking about a lot of data that other excellent investigators are doing. But the bottom line is, so far, is I think there is enough reason to believe that immunotherapy may work. We have across the board with different regimens, again and again, we see what we as a team usually call the exceptional responders that show really long-lasting exceptional responses. But unfortunately, it's not a treatment that works in all cases. Even if we look at larger studies, the TOPA study has shown a benefit, but I've got to be honest, as an oncologist, I can't be really satisfied with the numbers or the results that I see from that study. So one of the studies, and this is now data, preclinical data, I showed you the study in the KRAS mutated patients is obviously you can combine this with a immunotherapy. Again, this is now not human data, but preclinical animal data, and you can see that the combination is way more effective. And another study that we're working on is using the gemcitabine cisplatin that I'm sure a lot of you are well aware of, in combination with two different immune activating drugs, the PD-1 that we know, and then another antibody, anti-CD40. And again, this is based on preclinical work that we have generated in my laboratory. And then apart from this, we are very, very interested in other immunotherapy combinations. I mentioned some of them to you. I mentioned the adoptive T-cell therapy, and I think this is only the beginning of way more future studies. And then some of you may have heard my talk at the Cholangiocarcinoma Foundation meeting, which was so much fun, to see a lot of you again after such a long time. And we're very, very interested in studying the gut microbiome and how the gut microbiome can help make treatments more effective. And those studies are ongoing. But at the same time, I've got to be realistic. Right now, there are still future treatment options, and I don't think it's prime time yet to test this in patients. And with this, I would like to thank the group, the nurses, research nurses, physicians, nurse practitioners, and obviously people in the laboratory that helped me with this work. And I'm happy to take any questions.
All right, good, thank you. We do have a few questions. I am going to start here. So immunotherapy can target a specific genetic mutation is the first question from Dave. So I think he was referring to one of your slides when he was saying, so immunotherapy can target a specific genetic mutation?
Yes, so let me explain this. Try to explain this a little bit more. As you know, a tumor basically has genetic changes. It's different from healthy tissue because the cells under normal conditions would stop growing, but they have genetic changes that makes them immortal, and that's why they continue to grow and proliferate in the patients. So that means if you have a genetic change, this cell is actually different from a healthy cell. And this genetic change leads to a specific change in a protein, which is presented on the surface of the tumor cell. And this can be recognized by a T cell. So yes, there are specific changes, but the problem is that they are actually different in every patient. So every patient with their own tumors, and that's why sometimes now we do the sequencing of these tumors, we can actually look at all these mutations and then see which are potential mutations that can be recognized by T lymphocytes. And we do know that some patients, very few patients with cholangiocarcinoma, but those patients that have MSI high tumors, they actually respond very well to chemotherapy, to immunotherapy. And the reason is that these patients have actually way more mutations than others. And because they have way more mutations, they also have way more potential targets that can be recognized by the T lymphocytes. And that is basically why they respond so well to immunotherapy.
Okay. So Alex is asking, is immunotherapy only an option for those with unresectable tumors in cholangiocarcinoma? Which brings me to a question, is this something we can do neoadjuvantly or maybe after resection adjuvantly to try to keep the tumors away too?
Yes, so obviously, that's a very important and interesting question. And yes, it is being done both in the adjuvant and in the neoadjuvant setting in general. But we've got to go stepwise. We first have to show that you really show some efficacy before you jump ahead and say, we use this in the adjuvant setting. And don't forget, it's hard to ignore, even if none of us like the current treatment and the chemotherapy that we use in the adjuvant setting, they still do work. And again, I'm not a big fan of them. I'm not saying they work, as effective as we want them to work. And as Melinda said, I've been doing immunotherapy for many years. So I'm a strong believer in this. But, it also has to show enough efficacy. And in other indications, it does work and it's being done. And I know it's actually, I just came back from the ACR meeting and I know there are indications where it may actually replace surgery and radiation at one point. But as I told you, in cholangiocarcinoma, we're just not there yet because it's not effective enough.
Okay. Porter's asking, is there any success or efficacy being resulted in trials in cholangio patients that don't have any immune biomarker pathways, proteins, et cetera, like PD-L1, MSI high, or TMB mismatch repair? Thoughts on immunotherapy possibly being effective in patients that have targeted and treatable driver mutations such as IDH1 and 2 and FGFR2?
Yes, so that's a very good question. And actually, I would turn it the other way around. You remember I showed you we have responders, and we don't even know why they responded so well. So no, they didn't have all these markers. And we're trying to identify markers to, to find patients that will respond very well. And, the study that I've shown you and that others have done, the results are anything from being clear. So just because if you get the results back from a sequencing and they say there's so many, whatever percentage of PD-L1 or the mutation burden is so high, that does not say the treatment or the patient will respond to treatment, to an immunotherapy, yes or no. We are not, that is certainly not a statement that, you can make it. With the one exception, and that's what I, said earlier with the MSI high tumors where we know it works very well and we know the mechanism of action.
Okay. So I'm going to throw a question in real quick. Would it be efficient or efficacious, would it make sense to maybe study these exceptional responders, make a clinical trial for exceptional or long-term survivors of cholangio? Would that be helpful to find out why? Or would we all be different?
The problem is, I mean, that's basically what we're doing right now. We don't, before you don't know who will be an exceptional responder. Once you have an exceptional responders, yes, we try to find out, and that's what I try to show you with the slides, even if they are negative. We're really trying to do as much research and include any possible tests that we can do to find out why they respond. And I know from history, this is how we advance the field. And I don't know how much time I have and how many stories I can tell you, but you know from cholangio that, and I've mentioned this now twice, the story about the MSI high patients. The MSI high story is a story by chance. It just happened, that when the checkpoint inhibitors were initially tested after the success in melanoma, there was a study that was done in many patients with different indications. And there was a patient with colon cancer, and we knew that colon cancer patients would not respond very well. And all of a sudden, there was one single patient, similar to what I've shown you here, that responded. So the investigators, they started to scratch their head and think, why would this one individual patient respond, whereas the other patients did not respond? And it turned out, yes, he was an MSI high patient. And then, the whole story began, and that's why we know this. So yes, it is certainly of interest to study, these exceptional responders.
Okay, so what is the criteria for KRAS driven? Not sure, maybe the criteria for the KRAS trial?
So basically it depends on, you will get a sequence of your tumor and you will see a KRAS mutation in the tumor, and that is the requirement that you need to enroll, to be eligible for the study.
It doesn't have to be a certain KRAS
no.
type. Okay. Is there a role for immunotherapy in stage 1, node 0 after a resection?
Again, that's what I told you before, and at this point it is not. And let me be honest, immunotherapy can cause a lot of harm. I have seen patients that have severe side effects, and I know, again, I'm repeating myself here, I know everybody believes immunotherapy is the way to go, including myself, and sounds very gentle. But I'm always telling my patients, any treatment that really works can also have significant side effects. Otherwise, it would not work. I wish it was different, but I have never seen a treatment that doesn't have side effects.
Right. Okay, so new patients, how do new patients reach out to you?
They just send me an email.
Okay, we'll get the contact information and we'll
That's
share it with everyone.
all you have to do is Google me and you will find it immediately with all the information that you want, way more than I want to give you. No, I'm just joking. It's all available there.
Okay, I'm sure we can put that email up in the chat for you all
Yes,
too.
it was on the slide and everything, right?
Okay, and then, so what was the PD-1, anti-PD-1 and the anti-CD4 that's combined with the GemCis? Is there a name to those? I think you had showed.
It's pembrolizumab.
Was there another one? Was there?
That was the only one we used with GemCis.
GemCis, okay.
Mm-hmm.
Okay, so you talked about.
Sorry, we used it with, actually we didn't use it with, we actually use it with capecitabine and oxaliplatin. The GemCis was a mouse study, so there's no name for this because it's, we don't make brand names for mice.
Okay. So you talk about combining immunotherapy with chemotherapy. What about combining immunotherapy with directed therapy? Like that same question I think that Porter had, like treatments for FGFR2 fusions and IDH1. So more than one person is thinking about that.
That's certainly of interest. I don't, and that is ongoing. And we know there are experts who study this. So, and again, when I say experts, unfortunately, I have to tell you, these are still mainly preclinical studies. So, Nabil Bardizi, obviously from Harvard, I would say he's one of the leaders in this field. And I know you know him, he's really at the front line there, but it's way too early, to say or to even predict anything in patients.
Okay. So if you're considered MSI stable, does that mean immunotherapy is not recommended as treatment? Or does that just mean your chances are it might not work as well after talking about the MSI high?
So if you are MSI high, currently immunotherapy is approved. So it's FDA approved, no questions asked, it's straight, very easy. That would be the treatment of choice. If you're stable, you have to discuss this with your oncologist. I know that it's being used now based on the data from the TOPA study that I've shown you, but it's not approved yet. Now, approval does unfortunately not mean that it works in an individual patient. And it also doesn't mean that, the man is stable, will not benefit from the treatment. And, it goes either way.
Okay.
Trying to keep the positive here.
Yeah. So, okay. So could you comment on the use of immunotherapy for cholangiocarcinoma patients with spread to the peritoneal lining? Does the location of the spread matter? I mean, that's, I guess, the good thing about immunotherapy, right?
Yeah, that is actually a very interesting question. And I don't know if it matters, but I do know, because we study this a lot. So I don't know about the peritoneum, but I do know that the location matters. And the reason why I know this is because actually, tumors in the liver, for many reasons, and I don't want to bore you with this, the response to immunotherapy is very different than, for instance, if you have a tumor in the lung or anywhere else. So we do know that there are differences in depending on where the tumor actually grows, in what part of the body and in what organ. But I don't think we have enough data to tell you anything about the peritoneum yet.
Okay. Do lymphocytes in the patient's body need to be killed before all immunotherapy treatments, or just the CAR T cell treatment you discussed?
It's just the CAR T cell treatment. And the reason is, I told you and I tried to explain to you that you basically try to amplify these cells so that you inject enough cells. And we want them to proliferate and amplify in the body even much further. And we do know that they amplify much further if we take away lymphocytes before using chemotherapy. And that's the reason.
Okay. So how are immunotherapy agents administered?
Intravenously. But that's also a matter of change, So currently we administer them intravenously, but I know that there's a lot of companies and a lot of interest, and this will change, and they're trying to do this sub-Q and through different ways.
So, as in the CAR T and adoptive cell, that's a one-time kind of treatment, right? And then the
Yes.
the PD-1 drugs, That's like every 3 weeks though, right? It's not like a weekly chemo.
In most
comes out,
cases, it's either every 3 weeks or sometimes even every 4 weeks. Yes, it depends.
Okay. Are you using CTDNAMRD testing in patients on immunotherapy currently, or do you plan to?
We are planning to do this because remember I told you we're trying to get as much out of a patient in terms of information and to learn about this.
Will you explain what CTDNAMRD is for everyone on?
Yeah, sure, of course. So, you know, we're trying to understand, you know, what happens in the tumor. And, you know, one of the earlier questions was about mutations in the tumor. And there is a way that we can actually draw peripheral blood from a patient and use this blood and isolate circulating, that's what the C stands for, tumor, that's what the T stands for, DNA. So in other words, DNA that is derived from the tumor itself. And we can use this for two different reasons. Number one is we can actually get a number, and we can see, similar to a tumor marker, if it goes up or down, which we believe may correlate with the amount of tumor present or not. It's not a one-to-one, but, you know, it gives us a trend. That's number one. And then the second part is it will also tell us if there are specific mutations in the tumor, or the mutations may actually have changed, which is especially important in the context of targeted therapies where we use IDH targeting drugs or an FGFR inhibitor, for instance.
Okay. Is there a way that results from patients on immunotherapy outside of clinical trials can be shared to add to the common information base? So people who are maybe being prescribed immunotherapy drugs off-label?
You can do this. The problem is it's not very easy and straightforward. And the main reason is that a lot of the tests we do really require fresh specimen. So in other words, fresh blood. That is, you know, just an extra tube when you have the regular blood test anyhow. And even, you know, some of the tumor biopsy that's being done as a fresh tumor. So it's very difficult, you know, to just depend on already established, you know, biopsies that were taken somewhere earlier.
But I'll just throw out there too that you can contribute by joining patient registries and giving your information, your patient data, that help with research.
Right, and it's being done, you know. So you know, don't get me wrong. So this is something that, for instance, all the large sequencing companies do, and I don't want to, you know, give you any names because you all know them, but they have enormous amount of data. And they utilize this. So, you know, it may, and it's anonymized. So, you know, some of the data that you think, you know, you want to donate is probably already being used actually for that purpose.
Right. But make sure to join our patient registry.
Right, yes.
And contribute too. Okay, so what do you consider at minimal MSI high, as in a number value? What would be the number value for being MSI high?
It's actually not a number. It's actually a specific mutation or change that we see either that if we look at the tumor and either sequence this or look for specific proteins in the tumor. Because there are, so what I mean by this is when a cell divides, the cell actually unfortunately makes constantly mistakes. So, you know, the DNA has to divide from one into two cells. And unfortunately, there's constantly mistakes being made. So there's a whole system that we call the DNA repair system, which is kind of a little policeman, you know, that makes sure, you know, you want to make sure that the daughter cell looks exactly like the mother cell. And if there are little mistakes, you know, that these mistakes are being repaired by the system. Now, if one of these systems or these proteins that are part of the systems don't work because they are basically, you know, mutated and can't work, that will lead to mistakes when the cells divide, and then, you know, the more you divide, then the more mistakes you get. So what we do is we actually look for these proteins if they are intact, or if there are any signs that, you know, these proteins don't work as they should work.
And so how would a patient go about getting that testing to find out if they're MSI high?
So that's basically, you know, which, if you listen to the Cholangiocarcinoma Foundation, you should have heard by now that, you know, you need to get your tumor tested. And it's done with any biopsy that you send for molecular testing. It can also be, the small testing can be done by protein testing, but in the majority of cases, and especially in cholangiocarcinoma, this is basically what's done routinely when you do the sequencing.
Perfect. What do you think about liquid biopsies as an option for patient screening in cholangiocarcinoma trials when patients have specific alterations, or maybe when they don't have access to tissue for biopsy?
I wish it would work. We're just not there yet. And whenever I talk to these companies and people who actually do the sequencing of the tumors, I tell them that we know how difficult it is, and I know that the reality is that unfortunately I see a lot of patients, and then we don't have enough material and we don't get the result. So it's I think this is probably something that will happen in the relatively near future, but at this point, you can't really rely on the results yet.
Okay.
And especially, don't forget, if you want, there's always a difference between a research question and if you really want to make a clinical judgment about this. We can't afford, to make mistakes here. Imagine, you find a mistake, you find a mutation, and expose the patient to a specific treatment, and it turns out that actually this mutation is not present in the tumor. That would be bad.
Okay. Are you able to comment on NRAS mutations? Might MEK inhibitors work for NRAS? I'm often not sure if KRAS and NRAS can be treated in similar ways.
That's a good question, and there's a good chance that NRAS is not as susceptible to the treatment as KRAS mutations, but they are also way less frequent.
What would be considered an excellent response rate for cholangiocarcinoma?
That's an interesting question, and that's there is whole groups who ask what in cancer in general, what we should aim for, and and should you actually ask for a response rate, or do you need a survival benefit? I mean, obviously, you need a survival benefit. A response rate is nice, but ultimately, what we aim for is a survival. And and I think we need also to aim for a cure rather than a response rate. So that's my answer. Now, is this now 15% or 25 or 35%? That's very, very difficult. And how can I answer this? I mean, imagine I would tell you 25% is not good enough. We need 35%. But what are we going to do with the 25% of patients that would respond? I'm going to withhold the treatment from these patients. So I can't answer that question.
Yeah, and I definitely think sometimes a good response rate comes from what the patients believe is good.
Right.
No progression is great. Okay, you mentioned that patients with existing autoimmune conditions are not eligible for immunotherapy. That would include treatments that target specific mutations or markers as well?
No.
Okay. Unfortunately, I hear from a lot of patients with autoimmune disease. Are they always excluded, or is there an opportunity if their disease is controlled? How do you look at it from patient to patient?
It depends on the type of treatment you do and the autoimmune disease. Because obviously, there's so many different types of autoimmune diseases, so it really differs. And it also depends on whether you do a clinical trial or not. What a lot of the patients forget, and I understand this, and I'm not asking why this is. When I do a clinical trial, the number one thing I actually look for is safety. I don't ignore efficacy. We just discussed this, but I need to make sure that the treatments that I provide to a patient and deliver that are safe. You don't want to harm somebody unnecessarily. So if you talk about clinical trials, obviously, you're way more careful and are more likely to exclude patients with autoimmune diseases than if you treat them with what we call standard of care and an approved drug. And I'm sure the durvalumab will be approved rather soon. So now the good thing is that many other cancers, which are way more common than cholangio, are being used with immune checkpoint inhibitors. So oncologists have a lot of experience with checkpoint inhibitors, by now. So they actually do know who they can treat, and they do not exclude everybody anymore with a history of whatever colitis or psoriasis or whatever So I think that their things look very, very different But in the context of an immunotherapy trial where you're always trying to push the needle and make the treatment more effective than what we have, and when you make it more effective just because of the mechanism of action, you're obviously also more likely to get side effects. You've got to be careful.
Makes sense. Okay, we have about 4 more questions. Is the T-cell procedure considered Crispr, or is that something completely different?
That must be an expert. It is different, but it can be combined with CRISPR therapy. So CRISPR is just a way to exclude certain genes and say, you know, you want certain genes not to be expressed or to be expressed in a tumor. In this case, we actually use an antivirus to use this. But I know that there are ongoing trials where it's also being combined with the CRISPR technology for different reasons.
Okay, and then clarification, the number value for tumor mutational burden, TMB, what is considered high TMB?
Yes, I should know this, but I don't know it. I think it's 15 is currently the borderline for, because it's an approved treatment actually, if you have a high TMB. And I think it's 15, but don't, you know, I could be wrong with this because to be honest, I've never seen a cholangio with such a high tumor burden. And not mutation burden, sorry.
Okay. So question about immunotherapy and transplants.
Yes.
How does that work?
No.
Does
to
it
be
happen?
Honest.
Yeah.
So transplant is an excellent approach, which we know is, again, probably the most selective treatment that we can, or, you know, it's only for a very small group of patients. But we do know that it can interfere with immunotherapy. So there are 2 different scenarios. There's a scenario prior to transplant. And again, here I refer to the data that we have from patients with HCC, because there it is more common and we have a little, not a lot, but a little bit more knowledge. And there it is being considered in patients waiting for a transplant. If you stop early enough prior to transplant. The problem is that if you do this after transplant, if a patient recurs, that you always take the risk that you will actually get an acute rejection. And that is a dilemma, because if this is a severe reaction, you know, you need a new liver, and that would be a significant event.
Okay, so probably not going to happen a lot.
Not yet.
Okay. Are your findings regularly communicated with top cancer centers like MD Anderson, Moffitt, and Mayo?
Yes. Very straight answer. Yes, we all talk to each other. We all know each other. We exchange the data as soon as they come out. So, and last but not least, because we work for the government, we have to make everything publicly available anyhow, probably more than anybody else.
Okay. So you said patients with biliary stents are automatically excluded. If so, is it strictly due to the possibility of infection? And do you see this changing in the future, being so many patients with cholangiocarcinoma have stents?
This is an important question, but the individual basically goes, and I understand this, 2 steps ahead. We first have to show that the treatment really is safe and works. Once you have something that is safe and works, I think then you can see, can we potentially extend the indication and also, you know, consider a patient with a stent or not. But, you know, once we don't have this data available, you know, I would not take that risk.
Okay. What is the difference between an immunotherapy like Keytruda versus an inhibitor like ivosidenib? The IDH1.
Yes, right.
Yeah.
I mean, there's many differences. So one basically works on the immune cells. So the Keytruda works on the immune cells and the T lymphocytes and makes them more active. It doesn't do anything directly to the tumor, whereas the IDH inhibitor works directly on the tumor cells and targets specific changes in the tumor cell. And it's not considered an immunotherapy.
Okay. So one's, yeah, targeted drug, one's immunotherapy. I don't know. But thank you. That was a good explanation. Okay. quick follow-up on the Crispr question. Are they doing any clinical trials for Crispr for cholangiocarcinoma?
Not that I'm aware of.
And she said, thanks for calling her an expert. Okay, that is all the questions. Is there, if anyone else has any more questions, we have a few more minutes. You're welcome to put them in the chat. And Dr. Greten, we will share your email so
yes, please
know how to connect with you. I don't know if Rick or Emma, if you can put that in the chat real quick for the people who are online, and then we'll also post it on the website as well.
Yes, of course.
And people are saying, thank you so much. This was very helpful and interesting. Yeah, we appreciate it.
And they can contact me with questions too. I mean, not only for the trial. I mean, I'm always happy, to chat and give them, call them back and explain something to them.
Yes, and we appreciate you doing the second opinions. And again, the second opinions from Dr. Greten's team at NCI are more for people who are being seen in the community setting, not by the big academic centers, correct?
Yeah, I don't think, I don't want to compete with them, and I don't think, I rather serve the patients, that don't have an option to get to MD Anderson Memorial. We are in no way better than them. We're just, as good as they are.
Right. We just want to give patients access to a second opinion too. So that's perfect. Excellent discussion. Thank you. And we put Dr. Greten's email is in the chat box real quick for everyone who wants to take notice of that. And if you have any questions, let me know and I'll pass them on to Dr. Greten. And if you need anything, let us know. Thank you for joining us. And thank you, Dr. Greten. This was very informative.
Okay.
Everyone,
thanks
have
for
a
having
wonderful
me.
week. All
Thank
right.
you. Take care, everybody. Thanks. Bye-bye.
Bye-bye.